Fortunately, my father was there to give me.
We are live.
Okay, we're live. This is Senate Appropriations Committee. It's February 27th. We're talking about fiscal year 26 budget request. We have the Department of Mental Health with us today. I'll let you introduce yourselves for the record and get started when you're ready.
Right. And I am just not getting the link. So we're gonna do our best to do a slide here on. I'm Samantha Sweet and I'm Deputy Commissioner at the Department of Mental Health.
And I'm Shannon Thompson, the Financial Director for the Department of Mental Health.
And I'm gonna do a semi-quick overview for everybody. I think you might have seen some of these slides before, but we just wanna do a little bit of a refresher before I turn it over to my colleague. So we are the Department of Mental Health. In 2019, we started looking at what is our 10-year vision for mental health. And we came up with Vision 2030, which I'm sure you have heard about. And it is to promote and improve the mental health of Vermonters. And our vision is to have mental health be the cornerstone of health in Vermont. And as you will see as we go through this, many things that we will talk about and that we will continue talking about is really in our Vision 2030 plan. The next slide is an overview and to share with you who our partners are at Department of Mental Health. We contract with 10 designated agencies. We also contract with 2 specialized service agencies, which is NFI and Pathways. We also contract with 6 designated hospitals for inpatient care. We also run the Vermont Psychiatric Care Hospital, which has 25 beds in Berlin, and then River Valley Therapeutic Residence, which is 16 beds in Essex. That was the MTCR replacement. And then as far as staff positions, we have a total of 302. Majority are within our facilities of 233, and then 69 essential office. We have all the various like admin supports, quality research and stats, our clinical teams, operations, and as you can see, suicide prevention team, an adult mental health team, and children's mental health team. We contract with, as I said, majority of the hospitals for inpatient care, forensic psychiatrist. We have a psychiatric consultation with primary care for youth. We also work closely with law enforcement, courts, other agencies. We have a lot of partnerships with Vermont Care Partners, the Vermont Federation of Families, Pathways, NAMI, and so forth. As far as residential and crisis capacity in our designated agencies, we have 38 adult crisis beds. And when I say crisis beds, they could be from one night to up to a couple weeks, depending on someone's acuity and their need for extra supports. And then this is located within their own community. So every designated agency has a crisis bed program for adults. Youth crisis beds, we have 18 beds. Those are mostly within Chittenden County and Washington County. And then we have adult intensive residential beds, and that's 42 across the state. And those are, can be anywhere from 6 months to 18 months. And those are usually beds used for a step down from an inpatient psychiatric unit to, before they return to their community, they may need a little bit extra support and they can go to intensive residentials. Designated hospitals. We have, you'll hear, I'm sure you've heard level 1 used a lot, and most of those level 1 beds are for involuntary adults. And we have 57 beds in our system, and that's at BPCH, Brattleboro, Retreat, and Rutland Regional. We have 6 beds at Rutland Regional. And then we have non-level 1 beds, which can serve both involuntary and voluntary, and we have 128 beds in our system for that population. And then for children and youth, we have 30 beds, and all of those are located at the Brattleboro Retreat. Peer services, we have 2 crisis beds that is peer run. And then we have an intensive residential in the southern part of the state, and that has 5 beds. And then again, we have River Valley Therapeutic Residence in Essex that has 16 beds, and that's a secure facility, so that means it's locked.
The other state facility is also a secure facility, the central room.
What's that?
The state hospital is
Yep.
also a secure facility.
Yes, yep. All right, we're gonna move into the budget now, and I'll turn it over to Shannon Thompson.
Thank you.
Yeah, you'll just have to make sure your slides are.
Okay. So I'm going to try to go through these first couple of slides fairly quickly because I really want to be able to get into our budget line items that are on the ups and downs spreadsheet for you. So this just to give you a summary of our entire budget. We are requesting a total of $334,818,813. There's a number of budget ups that total gross of $7,101,586. Things for like salary and fringe, benefit rate changes, actually 64 parent rep stipends and training, internal service fund changes, PMI budget pressures, an additional federal and interdepartmental spending authority. We do have some budget initiatives for CCBHC, our reimbursement model for 2 agencies, and then alternatives to the emergency departments. And then we do have a couple of budget savings. So savings or transfers. So transferring money to DCF for some of our programs that we'll talk about. And then a couple of downs, savings, Howard Center's community outreach, and embedded clinicians in pediatric practices. So this chart also shows you what type of funding we have. We are primarily funded with Medicaid, very small portion of general funds, special funds. There are about $12 million of federal money in there. So that's just kind of an overview of our funding. This next slide is just to kind of show you where we spend our money, mainly on community services and resources. So we have a little bit of funding that we pay inpatient for. There's inpatient hospitals for level 1, and there's also the Vermont Psychiatric Care Hospital. But this is just to kind of show you primarily where we spend our funding. And then we'll just jump into the ups and downs. So does everybody have your, oh, do you have questions?
I do. Back on the next slide. I'm not familiar with Success Beyond 6.
Success Beyond 6. Would you like to talk through that a little bit?
Sure. Success Beyond 6. Oh my gosh, I'm probably not the expert of this, but it is funding to support kids in schools age 6 and above. You want to fill in any gaps?
Sure, we have, yes, so this is all designated agencies that have funding for, where the funding goes for Success Beyond 6. They all have contracts with schools, and they provide staff to assist children with special needs and such. And there's also a clinician case rate where a clinician might work with several families in addition to that. There's also some independent schools under that program.
Green, do you want to remind us what PNMI is?
Private non-medical institutions. Those are, again, for children. And I don't know a lot about the program around those, so.
Yeah, it's residential care for children. And so it's a special rate for those residentials.
And we have the ups and downs, if we're looking at our screen, which I'm usually the only one, so you can have it there, you could try to blow it up. But you could also, you don't go through every line, just give us the highlights.
Okay. Well, so I'll kind of lump some of these things together, but the first thing I will say is that we are proposing to split our budget into two pieces. Right now, our budget encompasses everything that we do, including the two facilities, the Vermont Psychiatric Care Hospital and River Valley, the therapeutic residence. And we're proposing to split those into two separate appropriations under our one budget for transparency purposes. So you're going to see the first line item here is just taking the personal services funding that is associated with those two facilities and moving it down into the facilities section of the budget, which we'll see a little bit later. So it's under the same, mental health budget, but two different appropriations.
Okay.
The first section here is our personal services, the salary and fringe, healthcare, retirement, those types of things. The total amount for all of those is a gross of $1,039,213. So all of those lines should add up to that for our personal services and fringe.
No new positions.
What's that?
No new positions.
No new positions. No, these are all our current existing positions. We also have an amount of a reduction of $5,336 for workers' compensation. You've probably seen that across the board. The next line item is other personal services. We have $237,000 under that line item for positions that we got in previous budgets, but we weren't able to, in last year in FY25, FY24, we were not able to actually bring all of those positions in. They were still sitting in another personal service line. Those positions are now part of our budget. We actually have the position numbers, so they're up above in the salary and fringe line. So it's just removing that money from other personal services because it's no longer needed there. It's up under our salary fringe.
Okay.
Let's see. The Act 264 by board stipends, that's $150,000, mostly general fund. And that is to pay for parent representation as mandated by Act 264, previously funded under mental health block grant. So that's what that funding is for. Any questions on that?
No, I think you could skip to the grants. I don't think there's anything in operating.
Okay, so, yeah.
None of this is new initiatives.
Not here, not the,
Nothing.
you're correct. The internal service funds is just our normal. We do have a technical, let's see, some technical corrections. Okay, you want to jump down to the transfer?
Great.
You want to go to the next page? These are just net neutral transfers, sending money back to DCF for a program that NCSS, Northwestern Counseling Services.
Yeah.
We had some DCF funding in our bundled rates, and that's coming out of our bundled rates, and we're moving those programs back to DCF. That's those two line items, the first two line items, the 846,000 and the 435. And then the next line item is very similar. It's moving the Addison County PCC funding back to DCF for the same reason. They're overseeing those programs now, so that funding is going back to DCF.
Okay.
We have a net neutral transfer from the Vermont Department of Health, their substance use division of $594,000. That is to support our new CCBHC program. CCBHC is Certified Community Mental Health, Integrated Mental Health program. And we have two organizations, Clara Martin Center and Rutland, who are going to become our first two CCBHCs. It is just a way to fund all of the services that are less than 24 hours in a different way, covering their cost using a single daily rate for each individual person who's seen during a day. So this is also encompasses substance use. So SUD is sending funding to DMH to support that program. The next line item is just the global commitment money that we need in our department to support that program as well. Any questions there?
This federal authority that you list as a BAA item, what is that?
So the federal spending authority, that is simply requesting spending authority for federal grants that we receive, and we've already received permission through the fiscal committee to spend that money, but we didn't necessarily have enough authority in our budget. So instead of asking for a special excess receipts request, we are asking to increase our budget.
But did you do it in the BA? Why do you list it as a BAA?
Because we also did this in our budget adjustment, so we just are letting you know that this is a BAA item as well as a fiscal year
So
26.
was it in the BA that we just passed?
BAA as well.
So you wouldn't need it here if that passed?
Yeah, this BAA is basically one-time funds. This is adding to our base, so that once it's in our base, we don't have to keep asking for it.
Okay, got it.
Similar with the interdepartmental spending authority, we have more collaborations with other departments. And that's the 472. The 500,000 is specific for our responsible gaming program.
Is that they send you?
They are sending us the funding.
And is it just always a flat $500,000?
Yeah.
Regardless of revenue?
Yeah. Yes.
Or-
That's what our current memorandum of understanding
And this
is.
would be the first payment,
Yeah.
right? Yeah, it'll be interesting to hear how it goes as things progress.
Yeah. Yeah.
Okay. I'll hold off my comments on the gambling situation.
Okay, so the next line item, private non-medical institutions, that's our PNMI, caseload and utilization request. That is simply pressures on our budget for caseload and utilization.
Yeah, so we've seen more kids need residential, and since the pandemic has ended, and so the PNMI ask is because we've seen more kids in need of residential, as well as the rates of PNMI have increased, and so this is also, so this is utilization and rate increases, you'll see.
You have a theory of why there's more need for residential care?
I do. I think there's a number of things going on with youth, that there's a lot of pressure since COVID has hit, and so we've seen a lot more schools struggling with kids in schools. We also know that a number of our beds in state, unfortunately, are still closed due to staffing, and so we're needing to look at other residentials, maybe in New Hampshire, Massachusetts, and surrounding states to help support our youth right now.
And that makes it more expensive.
Yes.
Okay.
So the next line item is just the inflationary increase for these private non-medical institutions. That is a change in the rates setting structure. They are allowing now inflationary increase as part of the rate setting process.
The alternatives to emergency departments, what is that program? How do you do that?
So we have 6 alternative TED programs that have started through the last year, I believe. And so a few of them are serving adults, a few are serving youth. And so we have enough funding until March. Thanks. We have enough funding until March of '26, and we need enough funding to get through to the end of the fiscal year. So the money that is being asked here is to finish off the fiscal year for those programs. An alternative TD, I should have
The
explained
next
this.
fiscal year, not this fiscal year. Or because you won't get this money till next fiscal year.
Correct. Alternative TD are programs that are in our communities so that individuals experiencing a mental health crisis do not need to go to emergency rooms. We're trying to give an alternative to spending hours in a pretty traumatizing area, and we want to open up community placements for them to be able to go and seek that mental health care, emergency care elsewhere besides the emergency room.
So we have 6 now?
We do have 6. I don't think it says it on this slide, but
And I couldn't
6 or
understand,
7.
I couldn't understand what you were saying it's funded for the whole year?
It's
Go ahead.
actually, our funding runs out in March, but we only,
Runs out
March of '26.
of 26?
But we're actually ending our contracts in December, so this is a half a year's worth of funding.
And what
That was
happens
my
after
mistake.
that?
Yeah. So what we're doing is gathering data now to see which programs are effective, and which ones may not. We're looking at regional approaches, so we put out, beginning of this, an RFP, request for proposals, to see who wanted to stand up an alternative to emergency room, program. And so now we're looking at regionally. Can we have ones regionally instead of just whoever responded to the proposal? And we're also looking at the data, like how many people are they screening? Is this making a difference? Are we seeing the emergency room numbers in that area going down because of the alternative program? So we're capturing a bunch of data and really looking at regional approaches.
So you'll be back here in budget adjustment?
Potentially.
Well, I would think if you're only half the year or to March, you're going to. And the whole issue of people with mental health issues ending up in the emergency room has been crushing to all of our hospitals. So I don't know.
We don't know exactly what that will look like, and that's why I said potentially, because we're trying to also look at Medicaid dollars. And is this an opportunity for us to draw down Medicaid dollars?
And you're not drawing down Medicaid dollars now?
No, not right now. This is all, right?
There's the only
Same
program,
global commitment.
so we have Northeast Kingdom is an investment right now, it's a Medicaid investment, but it's not pulling down Medicaid dollars in your traditional sense of providing a service that's billable. So we're working through all of that as well. So there is an investment for Northeast Kingdom Human Services, and then the rest of these programs, the Deputy Commissioner Sweet is talking about, if that's funded with our home and community-based FMAP program. So it's Medicaid, but it's a different bucket of Medicaid dollars where we don't have to.
Still
put up the general
match.
fund. We don't put up the general fund match.
There's no general fund match in that, so going forward after this, you'll have to, do something with the match. I can imagine that the hospital association is gonna be wild if you don't have a plan.
Right, the money that we have in here, the 866,000 is funding for half a year of the 4 that we are thinking that we're gonna be moving forward. So you're right, it's possible that we might have to come back for more, but this is getting some in the base to fund the additional 4 programs.
Additional to this, because you have the 6 that are on there right now.
Correct. And that's because some are not drawing down their full amount right now. So that's why we're really looking at which ones are seeing a lot of people. And so because some are not performing to what we expected them to, their funding can continue without any extra ask right now.
But there will be a proposal after this.
Likely. I don't know.
Well,
I think Senator Westman is expecting.
No,
I agree with you, yeah.
But,
Yeah.
it's been a crisis for the small
Yes.
hospitals across the state.
Yes,
And, people coming in and, sitting for hours in it.
yes,
And I
Yeah.
sat through the period of time where you couldn't contract with law enforcement to come into the
Mhm.
emergency room because the feds cut us out.
Yep.
This is not, if this goes away, it will be terrible.
yes.
As well for the patients, as you've mentioned, it's
Yes,
not a good place.
we
to
don't,
be.
it's not a good place. And so for them to seek mental health treatment or crisis care at all. And so we do expect to continue it. We don't know exactly what it will look like. We have done evaluations of how far is it for someone, if we look at a regional approach, how far will it be for an individual to drive to an alternative to emergency room program versus going to a local emergency room. Because we don't want the drive to be so far that there's an incentive just to go to emergency room. So we're looking at a number of things, just,
They don't come in and they don't drive here.
what's that?
Are you talking about them driving themselves?
I think family does drive, or some, it depends on location, right? Some take taxis, some come in through staff, some come in through the bus, some come in through families. So we do want to make sure, like, it's not, if we look at a regional approach, we don't want it to be an extra hour to drive here versus going to a local emergency room. So that's why we're looking at a lot of different data points for this. But we want it to continue. We're seeing a lot of positive programs, both at Northeast Kingdom and Howard Center really are doing an amazing job with this, and we do want to see programs like that continue. And especially we know in Washington County, a CBMC has closed down their inpatient unit.
Yeah.
And so we are looking at that area to, what can we do there as well?
Well, these people used to show up in mental health agencies. My mental health agency now, and like all of them, is locked down. And because the people coming in are some are coming in and are violent.
Mhm.
And, it totally, I can't stress enough that looking at this, it doesn't look like a full baked plan, and that does not make me feel real good.
Mhm. I think we do have a plan. We are looking at, there's a lot of support to look at regionally and making sure that that agencies are able to staff up, because that's also what we're seeing is some of these programs are not successful because they don't have enough staff to keep it open. And so we don't want to just continue that program and have there be staffing issues. So we're looking at a number of things, and I don't want to say that we don't want this to continue. We see there's a lot of support and we want these to continue. We don't want to see people going to emergency rooms.
Well, I would tell you what started this was a crisis.
Yeah. I would say it's been a crisis for a while with emergency rooms.
And an expensive crisis, because people end up there and they cripple emergency rooms and the staff around that. So it becomes way more expensive than trying to get ahead of this.
Yeah.
So the last few items we have here, let's see. Okay. We're requesting to convert some funding that was general fund to global commitment so that we can actually get more funding to support some of these Pathways programs. So Pathways received money 2 years ago to open a Bennington region. They needed some time to get it going, so it was all general fund, and some of the money has gone into housing supports. So the remaining funding is now, we're able to match it for Medicaid. So we're requesting to convert some of this money so that we can support some of their other programs.
Okay.
And then we have the Howard Center Community Outreach. That is a budget cut. The
This
outreach,
is a contract that you have with them.
I'm sorry.
Was this an agreement you had with them to do that outreach? So you're
Yes.
not renewing?
But we're not going to renew. What we're hoping is that those staff will be enrolled into enhanced mobile crisis to be able to dispatch from 988. And so we're looking at a systematic crisis approach of 988 being the call center, and then 988 can dispatch enhanced mobile crisis to provide 24/7 to those towns and cities. So this is very different than the street outreach that Howard Center runs just for Church Street. This is just community outreach to the surrounding towns and cities.
And then the next line item is the embedded clinicians. That is also a budget cut to Northeast Kingdom and Howard Center for both embedded clinicians and some of the staffing in the crisis center.
So this was a program that Howard Center had an embedded clinician with a pediatric practice in Milton, and that is a practice that is a blueprint practice. So they have blueprint staff that are in there. What we saw is the data showed anywhere from 10 to 12 youth a quarter were served by this individual, by this clinician. And so now that blueprint is in that practice, we don't, we're trying to look at the system as a whole and figuring out, not have these one-off programs, and what are we doing systematically. And that was a clinician that was embedded prior to blueprint going into that practice. And then there was one in Northeast Kingdom as well that they haven't hired for the last 4 years. So it's been open. So that's what that has changed. And then the other thing is there were some funds going into First Call for clinicians to help families sign up for insurance. And that's what the EPSET funding was for. And we have it in all our agreements that every program at our designated agencies should be helping everybody sign up for insurance. So it shouldn't be a crisis specific ask for that. And what we also saw through the data is almost 100% received already had insurance.
Good.
And I think there's one final item that we haven't talked about, and that is the shared living providers. That is just simply moving the money from Medicaid to general fund because of the way that we have to pay for these services now.
So what used to be our CRT program, which was Community Rehabilitation and Treatment, and it was our program to serve serious mental illness adults. And because of the HCBS rules, we have had to kind of reshape how we are looking at things, and there can no longer be a program that's called CRT, and as it needs to be rehabilitative instead of habilitative. And so with these, we have 8 individuals that are in shared living providers, and that is a habilitative approach. And so now we no longer can pay for it with Medicaid dollars, and it has to be in general fund. So it's a move from that to general fund. So services will not change for those 8 individuals. It's just how we have to pay for it.
Okay.
I think we got through everything.
Yeah, and then facilities, you just had moved.
Oh,
that
I'm
money.
sorry.
No, it's fine. You don't have to go, because you moved that money down into the
That's
facilities.
correct.
And everything else there seems pretty straightforward.
Right, there was no
Salaries,
special
healthcare.
asks there. It's just your traditional salary and fringe increases and operating, fee for space and
So
the accounting system.
You're having less vacancy savings, is that how I read this? Like you're more staff than you used to be?
The vacancy savings is essentially net neutral there, that is
Oh, yeah, I guess it is.
it changes very slightly every year, but we actually have over $4 million in vacancy savings in that line item for those two facilities because we offset that with travel partners, travel nurses.
Okay. But I assume you would rather have staff and not pay the travel.
We would much rather have staff, and
Yeah.
from what I understand, some of the recruitment efforts that we are going through have resulted in hiring staff.
We are partnering with less travel nurses and mental health techs, and we're starting to see the needle move a little bit with permanent staff and
Good.
lower travelers. It is
That'll
good.
help a lot.
Yeah, it will help a lot, both clinically and financially.
Right. And probably for the other employees,
Yeah,
they get paid less than the traveling
yeah.
around.
And it's tough to have people come in and out and you train them up and then they leave. You know, that's hard.
Okay. Well, thank you. Thanks for your work. Yes, Senator Westman.
I hate to do this, but at this point, and there's always a division between the department and the mental health agencies, but we haven't talked anything. The elephant in the room around all of this really is that our mental health agencies in most of our communities are literally in budget crisis. And I know that some of it's a Medicaid rate increase and is not specifically in your budget, but you do have grants and work back and forth with the mental health agencies themselves. You know, the state of the delivery of mental health services is nearly in crisis. And I don't know what, I'm almost at a loss of asking what to have help about this because all of our mental health agencies are nearly bankrupt.
Does that money go through you to the DAs or does it go directly to the DAs?
Much of it goes through us. They do have some direct federal money, I believe, and some other,
But any state money would pass through you.
The state money would pass through us and Dale. A little bit passes through the Vermont Department of Health for substance use, but primarily it's Dale and DMH.
And you're not, which is maybe part of your point, there's no increase for the DA mental health.
We do not.
And I don't know how they survive.
Yeah. Okay. Anything else you want to tell us?
That is all we have.
Okay.
That is it.
Thank you.
Thank you.
No other questions? We'll move on to the Department of Corrections. Are they on Zoom or maybe in the hallway?
Sounds like a great time to be.
Well, they might just walk right in. And all these people walk out, corrections will walk in.
Remember, I think mental health agencies are asking for a 6.5% rate increase.
Hi.
Hello, welcome.
Print out, would anyone prefer hard copy?
Is the commissioner?
He might be tied up in HCI still, but he'll come down to be released in
We don't need
timely, okay.
We know you have all the answers. If I have it on the screen, I'll just do that.
Okay.
Assuming it's on our website.
Okay.
Is this your section, Senator Norris?
Yep. I mean, yes.
Yep, that's fine.
Are we still live? Do you want me to
We're still
jump right
live.
into it? Okay, great.
I'll be right back.
Okay. You'll miss all the exciting.
It's gonna miss it. We'll be quick if you allow us.
Yeah.
Oh, we got four. We got four.
Well, do we still have Ann?
Ann is there.
Okay,
Okay.
we're good.
Yeah, can you do this setting so we can see you? Yeah, I like that better. We don't need to see us in the big screen.
I don't even think we need to see us.
Yeah, we're probably not enough. We know we're here.
Great.
Okay, yeah, you can introduce yourself.
Absolutely. Thanks for having me. Kristen Calvert, Deputy Commissioner for Vermont Department of Corrections. We have a two-part presentation. This one here is really a DOC 101. So depending on what folks need for that, probably don't need to do too deep of a dive.
I assume even though we have a new member on the committee, he's very familiar with Department of Corrections. I would assume there's other committee work, but I mean, we have the slides. You can do a quick walkthrough.
Sure.
Show the slide.
Yeah. So overview of DOC, as you know, we're housed within the Agency of Human Services, which is relatively unique from a national perspective. We're a unified system, so that means we house pretrial folks now, detainers, sentenced individuals, and also manage the community supervision aspect, so probation and parole most commonly. We have 6 facilities in state, 5 are men's facilities, 1 is a women's facility, and 1 out-of-state facility in Mississippi. There are 12 district offices or probation and parole offices, and we have a corrections academy in Lindenville. Our 26 budget request totals $230.8 million, and that's 95% general fund, and we have roughly 1,125 staff.
Did you fall within the governor's recommended 3% increase?
No, and that's, we'll get into that on the
Okay.
second packet for you. The next slides give a little snapshot of our population. We have 882 sentenced individuals and 551 sentenced individuals today. We have about 91% male, and that's really small, I apologize. The remaining are women.
Just,
Yes.
yes, before we move on, you
Oh,
said
sure,
you got 5 men's facility, or 6 in-state, 5 men, 1 woman.
correct.
Then you said, for our viewers, you said we have 1 out-of-state
One
men's
out-of-state.
facility with contract with an out-of-state.
That's
So,
correct.
just so they don't think you have an out-of-state facility.
Understood. Thank you for
We
that.
send people to an out-of-state facility.
We do.
How many people do we have out of state these days?
119 today.
And how's that compared to the last 5 years?
I would say it's significantly less. We did try to dial them back during COVID just because of the protocols, and ensuring the folks in our custody were, included in the same level of care that we have for the in-state population. Something new within the last fiscal year is that we now have folks on MAT out of state. That's the medically assisted treatment for opioid use disorders. That has a different per diem bed rate, but it does allow us more flexibility with that facility.
Yes. Bruce?
That's interesting. So this is in Mississippi. Do they have their own MAT program?
They do,
Yeah.
yeah. They stood up just for our staff, or for our population.
Oh, so not for anyone else?
I'll have to double check on that, but I know it's new for that system, generally speaking.
Interesting.
Do we not have it for in our facilities or?
We do.
Okay.
Yep, we just added that program down in Mississippi.
And then, do I remember correctly that it's cheaper if they're in-state, but if we don't have enough beds, that's when you send them to Mississippi, or is there other reasons you send them to Mississippi?
It's actually much cheaper out of state.
Oh.
Our in-state per diem cost for individuals, all of them, is about $299 per day. Out of state, it's more in the $60 to $80 range, depending on the type of bed they're occupying, if it's MAT or a general population bed.
And then, so you send a certain population there?
Yeah, we send folks there that have either completed programming or aren't eligible for programming until the end of their sentence. And so those folks are completing longer term sentences and don't need the level of care that we provide here.
Okay. And on this total sentences, total detained, the detained is that's the inmate population.
The detained is folks in our system that have not been sentenced yet.
Oh, and sentenced being sentenced and incarcerated.
And incarcerated, correct.
So you don't add those two numbers together?
We do add them together as far as our total population, but we like to show them separately so folks understand, the type of population.
And is the sentencing decrease, which is something we've been doing on purpose, but is that because we've been doing other things with this population?
Sure, are
Or
you?
because we're just arresting them?
Yeah, I mean, I think it's several things. Are you looking specifically at that drop in 2020?
Yeah, but just in general since 14, that's like pretty dramatic over the 10 years, but also that 2 years there during COVID, I guess.
There is. So COVID allowed us to release a lot of different folks that were serving, they were maybe less violent or lesser sentences. We also had JR2 come into play during that time. So a lot of those initiatives, again, allowed us to not incarcerate as many folks. I can't speak to the arrest numbers. I think that's something VST would have to speak to. But those are the two kind of main reasons why our population decreased at that time and has remained pretty steady. So those JR2 efforts in particular have been pretty effective.
Okay.
I just had one quick question.
Sure.
I assume you list you have a staff of 1,124 presently,
Those are the number of position numbers that we have.
and of those, how many are filled or vacant?
We have, in our facility is a 17.2% vacancy rate. The rest are pretty normal for state government in the 8 to 10% range. Speaking specifically about probation and parole and central office.
Thank you.
And that 17% is kind of where you've been, or that's down from the 20?
Yeah, we've tapered off at 17% through most of this fiscal year. We had a touch of a spike up to 19% over the last month and a half. That's pretty typical for us around the holidays anyways, but we have really normalized at that 17%.
What was it in the 20s a few years ago?
It was, I think 32% at the highest during COVID. So we've come a long way since that time. But.
Yeah. Okay, good.
I think we'll move into the staff costs, which is page 9 and 10 in that first packet. So this shows overtime costs and the amounts that they've increased over the last 5 years, 20%. This is a direct correlation to the vacancy rate that we've experienced, and also speaks to some side letters that we've entered into with the VSEA to try and boost those numbers and pay staff during those vacancies. Below that, the top line budget item, these are included. We'll talk about this a little bit later. The collective bargaining enhancements that went into effect in July that are driving the biggest portion of our budget requests this year. And that comes in the form of security differentials, which are hourly rates on top of folks' base pay, regular shift differentials, so working third or second shift, and right sizing to the new corrections pay chart.
Did you keep the new hour system? I forgot what it's called. It was like 3 numbers.
The 232, the 12-hour shift.
Yeah.
Yeah, so that was codified in the new bargaining agreement as well. And so these are also in addition to that.
It's 2 12-hour. What, how did it work again?
232, so it's 2 on, 3 off,
2 on.
2 on.
And 12
Essentially,
hour
they're
shifts.
getting in 12-hour shifts on those days. So essentially, they're getting about half the time in a pay period unscheduled. However, for transparency, because of the vacancy rate, folks are frequently getting held over for 16-hour shifts or additional shifts within that pay period.
And there's a mandatory overtime.
Some of it is mandatory, yes.
Okay.
Next page. This speaks to a little bit about the health of our population. 96% of our folks are receiving medication. 59% of that is a psychotropic medication. The average number of medications an individual receives is 5.5. And about
Average number.
right, yeah. And so about 2/3 of our folks are on the MOUD program for opioid use disorder.
And that, okay, 2/3 of it is opioid. Okay.
Our Emergency department visits have increased dramatically. We're at 650 for 2024. We're tracking in that same area for 2025, and that just really speaks to the health of our folks. They come in very ill, they have a lot of needs. Some of them have maybe not seen a doctor, and so when they get to us, they are seeing a doctor, which I think is really the reason for why they're on so much medication when they see us, is because they're finally getting treatment for those chronic illnesses.
And these are EDs outside the facility, they're not
Correct.
an internal.
Yep.
Okay. Yeah, it's a lot of money we're spending.
And then lastly, federal grants. We just wanted to outline for you all the grants that we're working with and tracking very closely on, to understand what maybe long-term implications might come about. The first one, CCD, this is the community college that's offered to both incarcerated individuals and to our staff, and now their staff dependents, where folks can take advantage of free college courses through that program. PREA is the Prison Rape Elimination Act, and this grant is aimed towards providing additional training and compliance with those standards. AIRS is the Adult Reentry Education program, where we're designing more vocational training opportunities for folks in our system.
You do that in-house or you contract with them?
We have, there's a number of different ways we do that. We do have staff embedded in the system that do that work. The AIRS grant just allowed us to evaluate the transition between the business model of the vocational training and then now the more training aspect of it. Second Chance does virtually the same thing. It's an extension of the AIRS grant. And then finally, our 1115 waiver. This is the Medicaid reentry waiver we received approval for in July that will go into effect January 1st of 2026. This allows the folks to access Medicaid benefits 90 days pre-release and then care management for post-release services. This will cover MAT treatment, some screening tools and evaluations, and allow that kind of care management bridge from pre-incarceration and to the communities.
Okay.
And that's it for that first overview packet.
You had that one last slide on community investments.
Oh, yeah, apologies. So we just wanted to highlight community investments that we make, largely in the transitional housing space, community justice centers, recovery centers, the Vermont Network, and then Kids Apart program through Lund. A lot of that work takes place across all our facilities, but a special concentration at the women's facility when you speak about Lund and the work with Divas and the network.
Okay. Some money for Jenna's Promise. Yes, Senator.
Yep.
Is this a grant program or?
They are mostly grants. There's 1 or 2 contracts for Lund, I believe, but majority of them are grants.
Like Jenna's Promise, like the chair was about to say, is a grant program.
Yeah.
And where they find these on the DOC website or?
Yeah, there's a listing on the DOC website. If you'd like copies of the actual grants, we can certainly get those for you.
Yes, I appreciate that.
Sure.
And what is the update on the women's prison? Seems like there was a lot of talk about that a couple years ago, and I haven't heard anybody
Yeah.
talk about it this year.
A lot of behind the scenes work still going on. There's 2 sites that we're contemplating in Essex right now. So we're working through what that process looks like with their planning committee.
There's no money in the governor's budget to address it this year.
Not this year, I think in subsequent years, but right now we have to narrow down the site and then we can start looking at permitting and other licenses and addressing funding needs at that point.
Did we put the money, maybe, wasn't there one year the
Design.
governor had put money aside too? Or was
Yeah.
that just design money? So that's still
Yeah.
there?
In the capital bill.
That is still there.
It's still there.
About 15 and a
I
half
was gonna
million,
say
if I'm not
13.
mistaken.
15.
Yep.
Okay. The ups and downs.
Ups and downs. What's on page 2 of that next packet? Do you have a preference as far as walking through annualization of salary and benefits?
Yeah.
Or would you like to go line by line? Happy to do
No,
either.
we do not want to go on.
Okay, that's fair.
Just
So,
anything that's out of the ordinary or that's.
sure.
Is there anything that's an initiative?
Or a new initiative, a new position.
There may be an extension of the initiative when we talk about pretrial services
Yeah.
specifically.
A couple of those things.
Okay, we can do that.
Things that might.
That would be great to have an update on that.
Yeah, absolutely.
Yeah.
Okay. So section B 33 or 335, excuse me, is the corrections administration. All we have here is salary and benefits, and then a couple internal service fund cost increases. Page 3, parole board, section B 336, same there, annualization of salary and benefits and internal service increases. Page 4, section B 337 is corrections education. Again, there is all annualization of salary and benefits and internal service fund.
The education that would include that workforce training.
No, workforce, vocational training is included in the correctional services, which is the next page, where we probably should spend some time.
Yeah, well, yeah.
That's where most of the magic happens, I say, and B 338, correctional services. The top several lines are annualization of salary and benefits. These are much higher than normal. Looking back to what we discussed about the collective bargaining agreement and incorporating those into our budget, that is the driver of the majority of that.
Wasn't there an RFR with correctional officers and together with the police?
No.
I thought that was separate.
That was separate. We do have a new pay chart though, so this right side is to that new pay chart, which fairly closely mimics the VSP pay chart. But there is more time on step in those first 6 steps, as well as an overall increase. So there is a significant ask in
And this
there.
is to help with, hopefully with vacancies.
That's the goal, yeah. Yes.
Okay.
So non-salary is all the way down that offender management system. That is just an annual negotiated rate increase for the offender management system. That's where we do all of our work with tracking where folks are within our system. Next down, the 2.4 million. This is the 3rd year negotiated contract increase for our health services contract. 2.4 million. Next down, our victim notification system is a year 5 one-time fee of 75,000. And then finally, statewide pretrial expansion, an additional 650,000. So last year, you'll probably remember we received 5 positions. We only received about 660,000, I believe, which doesn't fund the full 5 positions. But we do have one filled currently in Newport, and another one is currently being posted for St. Johnsbury. And we're also working on system enhancements with our offender management system, and we're with another electronic kind of tracking system called Fieldware to do that work with those folks. So it's ramping up slowly. And as we get more funding, we'll be able to expand it.
So when you say expansion, do you mean sites that are piloting it?
Yes.
Yeah.
Yeah. And we started in Newport. I think they have 2
Because
county
I thought there was
jurisdictions.
2 originally.
Yeah, so 2 counties, 1 office, Newport PNP handles both those counties.
Yeah.
And now we're expanding into St. Johnsbury for Caledonian County.
Got
it. So we're making our way through it, figuring out some things that we didn't anticipate, like multiple dockets and multiple counties and how to manage that. So it is progressing, just largely at the moment, depending on funding to staff those positions. The next several lines down under operating expenses are internal service fund increases or decreases. And the very last one under grants is the first, well, half a year because of the way the fiscal year falls, implementation for that 1115 waiver. So it'd be a decrease to general fund and an increase to Medicaid.
Okay, makes sense.
Section B 338.1, justice reinvestment, nothing there. That is where all the majority of those community investments we spoke about would land, all the grants for transitional housing and justice centers.
That's where how you use the justice reinvestment money.
Yeah. Next is the out-of-state bed, section B 339. This is only a contract. We have had some savings due to not sending as many folks out of state. So we've been able to maintain level funding there through those savings and accounting for the per diem rate increases that are built into the contract. Next down is section B 340, correctional, facilities recreation. These are all staff and internal service fund, excuse me, increases. And on page 7, which I think is our last section, B 341, this is the Vermont Offender Work Program. Last fiscal year, we moved a majority of those staff into correctional services under general fund. So this just peels off that final layer of staff salaries that remained in the budget. The next several pages are just notes for you that tie back to the ups and downs. And then the final page, the health and mental health contract. I just wanted to provide you an overview of what that contract costs year over year, the total for the 3 years, and then year 4 and 5 are optional extensions, which we haven't executed yet, but just so you can look ahead and see what those would cost the state.
I appreciate this summaries by appropriations page. Others don't do this. This is an easier way to do it, so I appreciate it.
Sure.
Have you ever seen others do that?
There he is. We don't need you. Perfect. Just kidding. Yeah, we're actually
still a huge budget pressure upstairs, so.
Yeah, that's actually it for us. If there's any questions, happy to.
Yeah, just looking over this highlights again to see
Sure.
if there's anything, but
My question is, what does the commissioner do?
He
yeah,
does a lot. I mean, you know.
I'm just the pretty face.
yeah. Kristen's got it all figured out, it sounds like.
I mean, you're certainly getting better answers if they're coming from her, so.
No, it seems. I don't have any other questions.
None from me.
We're good. Good job.
Senator Watson? No questions. She's good. All right.
Sounds good.
Thank you for your
This
time.
is the best testimony I've had.
Good job, Commissioner.
Yeah, thanks.
You're the closer. And